Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology, that is the Takotsubo Cardiomyopathy. So the Takotsubo Cardiomyopathy, it is one of the clinical condition where the event is reversible. It's an acute event and it's a reversible condition. And these patients, they present with the dyspnea, chest pain, palpitations. These are the common presentations. And they can also present with syncopal attack. They can also present in the acute heart failure as well. Now, let me discuss why it is called Takotsubo cardiomyopathy and what are the other names of the Takotsubo cardiomyopathy. All that we will discuss. So, I will be discussing the pathogenesis. I'll be discussing the clinical features and how do you diagnose, what is the criteria for Takotsubo cardiomyopathy, and how do you manage, in which I'll be discussing the diagnosis and as well as the treatment of Takotsubo cardiomyopathy. Right. So now first and foremost, you need to understand why is it called the Takotsubo cardiomyopathy. That is because the left ventricular apex, where the problem is there in Takotsubo cardiomyopathy, it is dilated and it is hypokinetic in such a way that the left ventricular apex, it is looking similar to that of an object called Takotsubo. This Takotsubo, it's an object which is used in Japan for trapping the octopus. Now this left ventricular apex, it is appearing similar to that of Takotsubo. That is the reason why it has been named as the Takotsubo cardiomyopathy. Now this particular Takotsubo cardiomyopathy, the another name of it is also called as the stress-induced cardiomyopathy. So what did I tell you in the beginning itself? It is an acute reversible condition. Right? And now the word Takotsubo, it is because of the morphological appearance. Right? Whereas the stress-induced cardiomyopathy, it is based on the etiology. Okay. So one particular terminology is being given based on the morphological appearance and the other name is being given based on the etiology. So that means the stress, it is the one which will induce the development of this Takotsubo cardiomyopathy. Now what is the other names of this Takotsubo cardiomyopathy? The other names of this is, it is also called apical ballooning syndrome. Why is it called apical ballooning syndrome? It is the apex which gets ballooned out. That is the reason why it is called apical ballooning syndrome. And the another name for this, it is also called as the broken heart syndrome. Now why is it called broken heart syndrome? Because the apex which has been ballooned out, it is very thin walled structure and there is very high chance that the apex which is ballooned out, there is chance of the rupture, and that is the reason why it is called as the broken heart syndrome. So the names given to this cardiomyopathy is Takotsubo cardiomyopathy based on morphological appearance, stress-induced cardiomyopathy based on etiology, apical ballooning syndrome depending upon which part of the heart is getting thinned out and ballooned out, and broken heart syndrome because it has the higher tendency of rupture. Now this broken heart syndrome or the apical ballooning syndrome, it was first, right, it was first diagnosed in a 96-year-old female. She presented with acute chest pain consistent with acute myocardial infarction, and there were typical ECG changes. The typical ECG changes were in the form of the ST segment elevation, but contrary to acute myocardial infarction, the coronaries were absolutely normal when coronary angiogram was done, and the 2D echo was showing apical hypokinesia, which is also consistent with the acute myocardial infarction. And these abnormalities on left ventriculography disappeared after 2 weeks. So this was the first case in the year around 1950s or 1960s, the presentation of Takotsubo cardiomyopathy was done. Now, what exactly is the overall definition of Takotsubo cardiomyopathy and how do we differentiate various types of Takotsubo cardiomyopathy, all that we will discuss now. So if you see the definition of the Takotsubo cardiomyopathy, as I have said you in the beginning itself, it is an acute transient left ventricular dysfunction. So transient in the sense it is a reversible condition. So it's an acute and a transient condition. And when I use the word transient, for how long this dysfunction will be there? So that will be there for nearly around 21 days. And this dysfunction, it is either systolic dysfunction predominantly, then there can be also diastolic dysfunction as well. Now, before the development of systolic or diastolic dysfunction in case of Takotsubo cardiomyopathy, there will be a preceding emotional, right? There will be preceding emotional or a stressful event, right? Preceding emotional or stressful event. And in these patients, when you do a two-dimensional echocardiography, that will show you that there is left ventricular regional wall motion abnormality. But this left ventricular regional wall motion abnormality, it is present beyond a single epicardial coronary artery, right? So in the sense, the coronary arteries, we have three important coronary arteries. One is left anterior descending artery, left circumflex artery, and right coronary artery. So this regional wall motion abnormality is not just confined only to the left anterior descending artery. It is the regional wall motion abnormality is present beyond the involvement of or beyond the supply of the left anterior descending artery. That is one important point. Next, how will be the apex in case of the Takotsubo cardiomyopathy is apex, it is ballooned out. Okay, you see this is B stands for ballooned out. Whereas how will be the base? The base will be hyperkinetic, right? The base will be hyperkinetic, whereas the apex, it is ballooned out and it is akinetic or hypokinetic. Okay, so that is what you will observe in case of the Takotsubo cardiomyopathy. Now, what are the other forms? Apart from the apex, the other forms are those which are localized to the base or the mid-ventricular region, which are localized to the base or mid-ventricular region, right? So this is the basic definition of your Takotsubo cardiomyopathy. So it's a clinical condition which is characterized by an acute transient systolic or diastolic dysfunction with preceding emotional or a triggering event with LV regional wall motion abnormality which is present beyond the distribution of a single epicardial coronary artery, with the apex being ballooned out and the base being hyperkinetic or the base being hyperkinetic. And the other forms include the base or mid-ventricular region is also being affected apart from the apex. Now, if you take the pathogenesis in these patients with the Takotsubo cardiomyopathy. So, pathogenesis as such in Takotsubo cardiomyopathy is very complex and it involves brain, heart axis, right? It involves brain heart axis, which is like little poorly understood, and I'll tell you what exactly is your brain heart axis. So what is the important point is there should be a significant emotional stress, and this emotional stress, either it might be a negative event or it might be a positive event. This emotional stress, or it could be even the physical stress. So this emotional or the physical stress that will trigger the neurological illness, or that will trigger the neurological circuit. Right? What exactly is that? I will discuss. So this emotional stress or physical stress triggering the neurological or psychiatric illness that will precede the development of the Takotsubo cardiomyopathy. Now, I said you that emotional stress, either it could be a positive event or a negative event. Now, in the pathogenesis, you take this emotional stress. 90% of it is the negative event, right? 90% of the emotional events are the negative events. Like what are those? Death of a nearby relative, or a motor vehicle accident with psychological trauma, natural disaster, fear, anger, family conflicts. So these are the negative events which can trigger the development of the Takotsubo cardiomyopathy. Whereas in 10% of them, it is the joyful events that can trigger the development of Takotsubo cardiomyopathy. What are those joyful events? Like birthday ceremonies, wedding anniversary, winning a jackpot lottery, unexpected joyful meeting with a friend or relative. So 10% of them, they are the positive events which can trigger the development of Takotsubo cardiomyopathy, right? And this 10% which are predisposing to the development of Takotsubo cardiomyopathy, this we call it as the happy heart syndrome, right? Happy heart syndrome. Okay, so this is about the basic pathogenesis. Now let me discuss in detail about this brain heart axis. Now in this brain heart axis, the parts of the brain which are being affected is either the cortex or the subcortical structures are being affected. And what are these subcortical structures? These subcortical structures include amygdala, next hippocampus, the next important structure is basal ganglia and hypothalamus. Right, basal ganglia and hypothalamus. So these are the subcortical structures which are being affected in the brain. Now, in these areas, there will be initiation of, right, in these areas, there will be initiation of the emotional triggers. Now, this emotional trigger which has been activated in these areas, they will initiate the release of the catecholamines, right? They will initiate the release of the catecholamines. So with that, like we have a theory called the catecholamine theory. So because of this, the emotional trigger or the physical trigger, there will be overstimulation of your cortical or subcortical structures causing excessive release of catecholamines. Right, excessive release of the catecholamines. And these catecholamines which are being released, they include excessive release of epinephrine and as well as the excessive release of the norepinephrine. These are released in excessive quantity in the acute phase. Now, these catecholamines which are released in excess quantity, they will come and act on the beta 1 receptors which are present at the apex. Okay, see, beta 1 receptors are distributed throughout the heart, but excessive or more number of beta 1 receptors are distributed mainly at the apex of the heart. So the beta 1 receptors are excessively stimulated by this excessively released catecholamines. So that will cause the intense contraction of the apex. Right, that will cause the intense contraction of the apex. Now, this intense contraction of the apex will make the individual to develop what is called as the contraction band necrosis. Right, will cause contraction band necrosis, and there will be also infiltration of inflammatory cells, or there will be infiltration of mononuclear cells. Right? So that is what is your catecholamine theory. So when you do an endomyocardial biopsy, so endomyocardial biopsy, what it shows? It shows the contraction band necrosis and infiltration by mononuclear cells. So that is what happens in case of the Takotsubo cardiomyopathy. So because it is the apex which is maximally affected, the apex where there is contraction band necrosis, that will get ballooned out. Okay, and that apex which is ballooned out, it becomes hypokinetic or the akinetic, whereas the base of the ventricle will be hyperkinetic. Now if you take this Takotsubo cardiomyopathy, we have two forms. One is primary Takotsubo cardiomyopathy and the other one is the secondary Takotsubo cardiomyopathy. Now this primary Takotsubo cardiomyopathy is that the one which occurs with or without a trigger. Right? The one which occurs with or without a stress or the stressful event. And this primary Takotsubo cardiomyopathy, it is most commonly seen in post-menopausal women. Right? Most commonly seen in the post-menopausal women. That is where you see this primary Takotsubo cardiomyopathy most commonly. Now, what will be the presentation of these individuals? They present mainly with the cardiac symptoms, that is in the form of the chest pain, palpitations, dyspnea, syncopal attack. These will be the cardiac symptoms that you come across in case of the primary Takotsubo cardiomyopathy. And definitely in almost 70% of individuals, there will be a preceding emotional or a physical trigger, right? Emotional or the physical trigger in almost 70% of patients, right? And in almost 25 to 30% of individuals, that is in 1/4 of patients, there is no clear trigger. Whereas you take secondary Takotsubo cardiomyopathy. Secondary Takotsubo cardiomyopathy is that this occurs in individuals with serious, right? This occurs in individuals with serious medical or surgical or an obstetric event. Right? This occurs in individuals with history of serious medical, surgical, or an obstetric event. Okay. And this secondary Takotsubo cardiomyopathy, what are those medical disorders? Either endocrine disorders in the form of pheochromocytoma. I'll just show you the entire medical, surgical, and obstetric event. Now, this is a table which is showing a differences between primary and as well as the secondary Takotsubo cardiomyopathy. So you take primary. So primary, what did I tell you? That almost 70% of individuals, they'll have a trigger, either the emotional or physical trigger. And this particular trigger, it is either the negative trigger or a positive trigger. So you take negative emotional trigger, that is nothing but your broken heart syndrome, whereas positive emotional trigger, that will be the happy heart syndrome. Now this negative emotional triggers, what all they include? They include like intense grief due to death of the spouse, parent, or nearby relative or friend, loss of property, anxiety and panic reactions, interpersonal conflicts, depression, suicidal attempts, major psychiatric illnesses, severe anger or frustration, retirement, debts, defeats, or the work stress. So these will be negative events. What are the positive events which can predispose to Takotsubo cardiomyopathy, like which we have already discussed previously also, like birthday parties at the age of 50 to 80 years, wedding, unexplained happy meeting with a friend or relative, becoming grandmother, winning a big lottery or unexpected huge financial gains, happy ceremonies and various happy events. These are the emotional triggers, and along with that there can be even the physical triggers as well. So these are the one which will predispose to primary Takotsubo cardiomyopathy. Next is secondary Takotsubo cardiomyopathy. What did we discuss? Either there should be a medical or obstetric or a surgical event. You take the medical endocrine disorders in the form of pheochromocytoma, multiple endocrine neoplasia, autoimmune polyglandular syndrome, SIADH, then thyroid disorders. Neurological disorders in the form of subarachnoid hemorrhage, acute head or spinal injury, acute neuromuscular crisis. Respiratory disorders in the form of acute exacerbation of COPD and acute ventilatory failure, that is obstetric emergencies and cesarean section, and psychiatric disorders. Okay, so these are some medical disorders which can predispose to Takotsubo cardiomyopathy, that becomes secondary Takotsubo cardiomyopathy. And acute sepsis, acute gastrointestinal disorder, dobutamine stress echo, excessive IV catecholamine infusion following general anesthesia. So these comes under your secondary Takotsubo cardiomyopathy. Now overall, if you take the clinical profile in case of the Takotsubo cardiomyopathy, what would be the most common presentation? So what did we discuss? Even though this Takotsubo cardiomyopathy is present in both males and females, it is most common in postmenopausal women, right? And there should be a preceding emotional or the physical trigger. So the most common clinical feature in Takotsubo cardiomyopathy will be chest pain. And this chest pain, it is present in almost 75% of patients, right? So what could be the reason for the chest pain? See, like the apex, initially it is hyperkinetic because of excessive action of the catecholamines, right? And once there is excessive contraction, the blood supply also should, that means the demand will be more, and if the supply is less, the individual will suffer with a sort of ischemia. So thereby the individual will have chest pain. The other point is dyspnea. So this particular dyspnea is mainly because of development of acute left ventricular failure secondary to Takotsubo cardiomyopathy, and this is seen in almost 25 to 50% of patients with Takotsubo cardiomyopathy. Subsequent to this, these patients, they develop palpitations. Why is that they develop palpitations? Is because increase in the heart rate. So there can be development of even arrhythmias that will make the individual to develop the palpitations. And syncopal attack. This syncopal attack, why is that due to? That is because of decrease in blood pressure, and due to which there is decreased cerebral perfusion causing syncopal attack. And this syncopal attack, it is present in almost 25 to 40% of patients. And next to the syncopal attack, very important is there should be a trigger, right? Along with this, there should be a trigger. And on examination, what is that you will notice? There is tachycardia, the heart rate is increased, and there is hypotension in these individuals because of decrease in cardiac output because of hypokinesia of left ventricular apex. And on when you auscultate the lungs, there will be bilateral basal crepitations, and this bilateral basal crepitations are mainly because of development of pulmonary edema. So this is the clinical profile that you come across in patients with the Takotsubo cardiomyopathy, right? And these patients, they also have an obstructive events, and that obstructive event is in the form of systolic anterior motion of anterior mitral valve leaflet. Now, why that obstructive events develop? Let me try to explain to you clearly. Okay, so why there will be obstructive features? So this obstructive features is mainly because of systolic anterior motion of mitral valve leaflet. So what is happening here? There is LV contractile abnormality, and this LV contractile abnormality, right, this LV contractile abnormality is predominantly found or prominently seen at the apex, LV apex, right? And that is the reason why it is called apical ballooning syndrome. And at the apex, the 2D echo will show you that there is regional wall motion abnormality, and this regional wall motion abnormality, it is confined to the mid ventricular region, right? Or it may be even seen, it is commonly seen in the apex, and that can even progress to the mid ventricular region as well. And this regional wall motion abnormality, what did I discuss in the definition itself? It is present beyond the distribution of a single epicardial coronary artery, right? And why is this particular SAM present? Let me try to explain to you. So here what exactly happens is the apex, right, it will be hypokinetic. So you see the next image, the apex will be hypokinetic or akinetic, whereas how will be the base? Base, in order to compensate the LV apical hypokineticity or akineticity, the base will be hyperkinetic, right? The base will be hyperkinetic. So because of that, what will happen? Because of that, the anterior mitral valve leaflet, whichever is there, it comes in the area of left ventricular outflow tract. So during the mid part of the systole, because of compensatory hyperkinetic base, the anterior mitral valve leaflet, it comes in the way of left ventricular outflow tract, and thereby it will cause left ventricular outflow tract obstruction. And this left ventricular outflow tract obstruction is due to what? This is due to systolic anterior motion of the mitral valve leaflet. And because of this left ventricular outflow tract obstruction, there is a significant gradient which is developed between the left ventricle and as well as aorta. And not only that, because of decrease in cardiac output, there will be also hypotension in these individuals. Okay, so this is the clinical picture. So why the individuals can have syncopal attack, or why do they have this chest pain? Because of decrease in cardiac output. So demand is more for the LV apex, but the supply is less. That can cause ischemia and chest pain. And because of decrease in cardiac output, there will be also decrease in cerebral perfusion causing syncopal attack. Then what exactly are the complications? See, overall in Takotsubo cardiomyopathy, the prognosis is good, right? That means within 21 days, the transient hypokinesia or akinesia will revert back to normal. But in 1.2% of in-hospital patients, right? In 1.2% of in-hospital patients, they develop rare complications. What will be that rare complications? That includes irreversible cardiogenic shock, and this is very common in secondary Takotsubo cardiomyopathy, which is secondary to medical, surgical or the obstetric illness. And the apex, which is like very thin walled, it can rupture. So the next important event is the left ventricular rupture, and next is the LV. The LV apex, it is akinetic or hypokinetic. So there can be stasis of the blood at the apex. And this particular stasis of the blood at the LV apex will progress to the thrombus formation. So there can be thrombosis, and this thrombosis, it can get ruptured where there can be embolization, right? So there will be a thromboembolic event. This thromboembolic event can present in the form of an acute MI, or the individual can develop acute cerebrovascular accident. And this LV apex, which is ballooned out, it is arrhythmogenic. So the individual can develop VT or VF, and where they can also have a sudden cardiac death, right? And these patients, they have long QT interval. And this long QT interval, that can progress to polymorphic ventricular tachycardia, which we call it as the Torsades de Pointes, right? And very rarely there can be even complete heart block as well. So these are the complications which are seen in almost 1.2% of patients with the Takotsubo cardiomyopathy. Otherwise, the overall the prognosis is good. Then how do you diagnose? See, diagnosis is by ECG, cardiac biomarkers, 2D echo, and then the coronary angiography. What will be the findings? I'll discuss now. So the first important is the ECG showing the significant STT changes. What will be that significant STT changes? In majority of the patients with Takotsubo cardiomyopathy, like for say in 43% of individuals, there will be ST segment elevation, right? But rarely, that is around 8% of individuals, there can be even ST segment depression as well. That will be the STT changes. And how will be the T wave? The T wave, it is inverted in case of Takotsubo cardiomyopathy. And how will be the QTC interval? The QTC will be prolonged. And how much it will be prolonged? Normal QTC is around 360 to 440 milliseconds. But here the QT interval will be prolonged to more than 500 milliseconds. This prolonged QT interval, right, that can progress the individual, or that can make the individual to develop the VT or VF. Okay. So, and what type of VT? There will be polymorphic ventricular tachycardia, and this polymorphic ventricular tachycardia will make the individual to develop a sudden cardiac death. Now, the very important point is the ECG, it cannot differentiate, right? The ECG, it cannot differentiate the apical ballooning of the apex, right? It cannot differentiate the apical ballooning of the apex of Takotsubo cardiomyopathy and acute MI, right? It cannot differentiate the apical ballooning of the apex of Takotsubo cardiomyopathy from an acute MI regional wall motion abnormality. So for that, subsequently what is required? The 2D echo is required. But before that, you see the cardiac biomarkers. See, cardiac biomarkers which are being elevated are BNP and as well as NT-proBNP. They are elevated in higher quantity than compared to that of the troponins. Even troponin is also elevated, right? Troponin I and troponin T, both of them are elevated, but significantly it is your BNP and NT-proBNP are much more elevated than compared to that of your troponin. Now this BNP and NT-proBNP, they may be increased almost 3 to 5 times, right? They are increased almost 3 to 5 times then compared to that of the troponin, right? Then compared to that of the troponin. Okay. And this BNP and NT-proBNP, they are considered more useful diagnostic biomarkers for Takotsubo cardiomyopathy rather than the troponins. I'll just show you a table as well. Okay. So you just observe this table, right? The NT-proBNP in Takotsubo cardiomyopathy, it is almost like 4702. Whereas the troponins, they are like 2.1 nanogram per ml and CKMB 9.5 nanogram per ml. So your NT-proBNP is much more elevated than compared to that of troponins and as well as the CKMB. Whereas you take in case of acute myocardial infarction, that is in case of STEMI. So in case of STEMI, your troponins, right, they are elevated, but you see how much they are elevated. Like this is 19 nanograms per ml. Compared to that of 2.1 in case of Takotsubo cardiomyopathy. So in case of acute MI, your troponins are much elevated than compared to that of your NT-proBNP, right? So this is how you can differentiate based on the biomarker levels which are significantly elevated, whether it is Takotsubo cardiomyopathy or the STEMI. Now the next important is the 2D echo, right? This already we have discussed, but let me just quickly recap like what will be the echocardiographic finding. So first and foremost, there will be a very large area of regional wall motion abnormality, and this regional wall motion abnormality, it is present in more than or beyond the distribution of single epicardial coronary artery. Right, it is present beyond the distribution of a single epicardial coronary artery, right? That is one point. And next important is the apex, not only hypokinetic, it is also ballooned out. Now it is not only the apex which will be ballooning out, there will be also dilatation of mid-ventricular region. Right, there will be also dilatation of the mid-ventricular region and the ejection fraction will be reduced. See, normal ejection fraction is 55 to 70%, but here the ejection fraction, it will be reduced to 20 to 45%. That will be the ejection fraction in patients with the Takotsubo cardiomyopathy. And next, there will be also SAM, that is systolic anterior motion of anterior mitral valve leaflet. And because of this SAM, the patients will also have the mitral regurgitation, because during the systole, the mitral valve leaflets, they should close completely. But here what is happening during the systole, or exactly during the mid part of the systole, anterior mitral leaflet is moving towards the septum. So thereby the blood from the LV, instead of moving into aorta, some amount of blood will leak into the left atrium, and that will result in what is called mitral regurgitation. And because of this SAM, we can also demonstrate that left ventricular outflow tract obstruction is being present during the mid part of the systole. And this obstruction can progress the individual to develop the acute heart failure, right? Can progress the individual to develop the acute heart failure. So this will be the 2D echo findings in patients with the Takotsubo cardiomyopathy. Then coming to the angiography. So if you take the angiography, this is one of the emergency investigation. Why is it am I telling as the emergency investigation? Because you should be able to differentiate whether it is Takotsubo cardiomyopathy or acute myocardial infarction. So to differentiate whether it is apical hypokinesia just because of Takotsubo or coronary artery disease, you have to do coronary angiogram. And in case of Takotsubo cardiomyopathy, there is no obstruction, right? There is no obstruction within the coronaries, right? There is no thrombus, right? Or there is no plaque. Okay, so that is what you will see within the angiography. But in 10% of individuals, there can be a mild atherosclerosis. But this mild atherosclerosis, which is there in less than 10% of cases, this will not explain, right? This will not explain the severe LV dysfunction, right? This will not explain the severe LV dysfunction. Okay, and next is the CT angiography, right? Next is the CT angiography. The CT angiography, it is performed using 64 slices, right? Using 64 slices CT scanner. And this CT angiography, it is considered as best method, right? It is considered as best method for diagnosing myocardial bridging, right? For diagnosing myocardial bridging. Okay, so this myocardial bridging, you will be able to appreciate particularly during the diastolic phase of the heart, right? Whenever there is filling of the coronaries during diastole, right? If there is a myocardial bridging, you will observe that there is attenuation of the coronary artery during the diastolic phase, and that you can make out by the CT angiography. Now, why this particular myocardial bridging has come up in this scenario is because you need to know the cause of the hypokinesia. Is it because of myocardial bridging the blood supply to the apex is reduced, causing hypokinesia? Even that also you have to rule out, and that you will be able to rule out by doing the CT angiography. And next important investigation is the cardiac magnetic resonance imaging. See, this CMR, this will provide the three-dimensional view of right ventricle and as well as the left ventricle, right? And the four major anatomical patterns of regional wall motion abnormality can be made out, right? Four major patterns of regional wall motion abnormality can be made out in Takotsubo cardiomyopathy. And what exactly are those four major patterns? I'll discuss. Okay, and usually it is the left ventricle which is affected in case of Takotsubo cardiomyopathy, but in almost 20 to 30% of individuals, there can be involvement of the right ventricle as well, and that can be recognized by cardiac magnetic resonance imaging. Now, this CMR, what it will show you is what is the indication, right? That shows within first 7 days, right? Within first 7 days of development of Takotsubo cardiomyopathy, you will notice that there is regional wall motion abnormality, and at 2 to 6 months, right? At 2 to 6 months of development of Takotsubo cardiomyopathy, you will notice that there is recovery, right? There is recovery from regional wall motion abnormality, right? So that is what you will be able to make out in cardiac magnetic resonance imaging. And the another important point in the MRI, that is late gadolinium enhancement. Late gadolinium enhancement can demonstrate an acute myocardial infarction, right? In acute myocardial infarction, there is late gadolinium enhancement, whereas this late gadolinium enhancement, it is absent in case of the Takotsubo cardiomyopathy. So now let me discuss what are these 4 major patterns of regional wall motion abnormality in cardiac magnetic resonance imaging, right? These 4 patterns include: number 1, the majority will be the apical ballooning, that is apical hypokinesia. There can be mid left ventricular dilatation in 10 to 15% of individuals. There can be inverted, that means basal dilatation will be there in 5% of patients. The rare variant is either focal, global, RV or biventricular, but that is a rare variant. So these are the 4 forms of the regional wall motion abnormality that can be made out in the cardiac magnetic resonance imaging. So accordingly, you see this, right? So this is your typical Takotsubo cardiomyopathy where the apex is ballooned out, whereas reverse is what it is, the base which will be ballooned out, the apex will be normal. Whereas mid-ventricular, it is only the mid part of the ventricle which is like ballooned out and hypokinetic or akinetic. And the last one, which is a rare form, it is localized, global, RV type or biventricular type, right? And the next important point you need to know is like how will be the appearance of the coronaries in the cardiac magnetic resonance imaging. So you can just see this profile, right? So this is a diastolic frame. So in the diastolic frame, the first image, you can see the coronaries, they are absolutely normal in case of Takotsubo cardiomyopathy. You don't have any obstruction at all. In systolic frame, you will be able to make out the apical ballooning. Okay, so this is the systolic frame in cardiac magnetic resonance imaging. So these are the diagnostic modalities, like investigations that you have to do in Takotsubo cardiomyopathy. What is very important in this coronary angiography, appearing normal is a very, very important point to differentiate the acute MI from the Takotsubo cardiomyopathy, right? And the next is the criteria. So we have 2 important criteria to define the Takotsubo cardiomyopathy. One is the Mayo's criteria, that is Mayo Clinic criteria, where that is one criteria. 4 criteria is there, all the 4 should be there for diagnosing Takotsubo cardiomyopathy, that is one thing. And next is the European Heart Failure Association criteria. Okay, we will discuss both of them. And in Mayo's criteria, you have 4 out of 4 should be there to call it as Takotsubo cardiomyopathy. What are those 4? Right, whatever the investigations we have discussed now, that is the 2D echo should be showing hypokinesia or akinesia of the apex, and there should be a preceding trigger, either physical or the emotional trigger. So transient hypokinesia or akinesia of the apex, regional wall motion abnormality should be there. Next is the ECG abnormalities. The ECG abnormalities, typically it is ST segment elevation, right? And other ECG changes are rarely in 8% of individuals there can be ST segment depression, T wave inversion and long QT interval. Along with that, the biomarkers are also included in the second criteria itself, that is your NT-proBNP are elevated and even the troponins are also elevated. And the coronary angiogram, it should have no obstruction at all. There should not be any atherosclerotic plaque. There should not be any thrombus, nothing. So absence of the obstructive lesion. And lastly, absence of an endocrine disorder where there can be massive release of catecholamines, that is pheochromocytoma. There should be absence of pheochromocytoma and as well as the prior myocarditis as well to diagnose Takotsubo cardiomyopathy. Because in primary Takotsubo cardiomyopathy, there is massive release of catecholamines secondary to a emotional trigger. And even in pheochromocytoma also there is massive release of catecholamines secondary to the adrenal medullary tumor. Right? And to call it as primary Takotsubo cardiomyopathy, you should not have the presence of the pheochromocytoma. So 4 out of 4 should be there to diagnose the Takotsubo cardiomyopathy, right? Next. Now coming to the European Heart Association diagnostic criteria. That is number 1. So almost same, whichever are there in modified Mayo Clinic, same are there in even European Heart Association, but they have split. And that's the reason why the number is increased. What are those? I'll tell you. So one is regional wall motion abnormality, right? And this regional wall motion abnormality of the LV, which are frequently but not always preceded by the stressful trigger. But what modified Mayo Clinical criteria tells you that there should be always an emotional or physical trigger. But European Heart Association says not always preceded by a stressful trigger, because the secondary Takotsubo cardiomyopathy, there need not be a trigger. Right? That means emotional trigger need not be there. It could be either secondary to medical, obstetric or the surgical condition. Right? And even we have discussed in almost primary also 25 to 30% of individuals there is no trigger at all. Right? That is the reason why European Association said it need not always be a preceding trigger. And the next is regional wall motion abnormality, which is present beyond the distribution of single epicardial coronary artery. That is second criteria. Third, ECG changes, right? ECG showing ST segment elevation, T wave inversion, long QT interval. And fourth, biomarkers BNP and NT-proBNP are elevated. This third and fourth together they are given in the second criteria in modified Mayo's criteria. And next is the cardiac troponin are also being elevated, not only BNP, even troponin. Then absence of culprit atherosclerotic disease. That means coronary angiogram should show that there is no obstruction at all. It should be absolutely normal. And the last one is recovery of the ventricular function on cardiac imaging on follow-up. Okay, there should be recovery of the regional wall motion abnormality. That should be there on the cardiac imaging. This last one is not there in the modified Mayo's criteria. So this is about your European Heart Association criteria. Then overall, how will be the prognosis in these patients with the Takotsubo cardiomyopathy? So we have discussed this in the beginning of the session itself, that overall prognosis is good. So it's an acute reversible event. So the prognosis is good in these individuals, but very rarely, in almost 1.2% of patients who are hospitalized, they may develop the complications, right? And what are the complications that we have discussed in the clinical picture also? But let me tell you again, there can be development of a cardiogenic shock, right? And there can be also another important complication like rupture of the apex. There can be life-threatening arrhythmias, right? And next important is thrombus formation at the apex, and there can be even sudden cardiac death secondary to polymorphic ventricular tachycardia. So this is about the prognosis. So overall the prognosis is good. So even if you take the mortality also, there were many studies which have been done to look for how the mortality will be is. So one of the study, like a meta-analysis of many studies were done of almost 2120 patients. Out of that, 37 studies from 11 different countries, the in-hospital mortality of Takotsubo cardiomyopathy was only 4.5%. And one more study showed, in recent study on trends in hospitalization of Takotsubo cardiomyopathy in USA, in-hospital mortality is 1.1% in primary Takotsubo cardiomyopathy and 3.2% in secondary Takotsubo cardiomyopathy. And what was the cause of the mortality? That is cardiogenic shock, respiratory failure, and as well as the cardiac arrest. And what has been found is, even that mortality, whatever is happening, it is higher in men than compared to that of women in Takotsubo cardiomyopathy. So overall, if you take primary and as well as secondary Takotsubo cardiomyopathy, the mortality rate is around 1 to 5%. Now you should know which group of individuals are at highest risk of development of the mortality. That means you need to know, or you need to understand the indicators of the high risk. First and foremost, the age. Elderly individuals, age of the individual 75 years, they are at increased risk of the mortality. And next is the presence of the serious complications. So what are those serious complications? These serious complications that includes development of the pulmonary edema. They are at increased risk of respiratory failure and then cardiac arrest, and cardiogenic shock. They are at increased risk of mortality. Then the individuals who have developed serious arrhythmias, they are also at increased risk of sudden cardiac death. Next is, if the ejection fraction, if it is less than 35%, even after 21 days, they are also the one who are at increased risk of the sudden cardiac death. Next is those patients who have a very thin walled, the LV apex. Okay, so there can be LV wall rupture. So those individuals who have LV wall rupture or who has developed the thromboembolic events, right, who has developed this thromboembolic events, they are also at high risk for the development of Takotsubo cardiomyopathy. Next, those patients who have biventricular involvement. So what did I tell you? It is usually left ventricle, but in 20 to 25% of individuals, there can be biventricular involvement. So wherever there is biventricular involvement, they are also the one who are at increased risk of sudden cardiac death. And those patients who have prolonged QT interval. So QT interval more than 500 milliseconds, they are at increased risk of sudden cardiac death. And those patients who have the BNP levels which are elevated to 600 nanograms per ml, they are also at increased risk of sudden cardiac death. So these are the indicators of high risk for the development of mortality in patients with the Takotsubo cardiomyopathy. Now, if you take the management of primary Takotsubo cardiomyopathy, right? So there is no specific therapy for Takotsubo cardiomyopathy, right? There is no specific therapy, right? And fortunately, what we have seen or what we have discussed, that Takotsubo cardiomyopathy, they have favorable prognosis. Almost like 95% of individuals, they'll have favorable prognosis and they will recover back by almost within a year, within half an year. So within 3 to 6 months, majority of them, they will recover. And there is no specific therapy. So what is the ideal goal? The ideal goal is to sustain the life and give supportive treatment, and this supportive treatment should be given to tide over the complications, like the individual develop pulmonary edema, right? You need to monitor the blood pressure and accordingly you need to give diuretics. And the individual had developed VT or VF. So accordingly, if the individual is hemodynamically unstable, you need to give DC shock. If the individual is hemodynamically stable, then you need to give antiarrhythmic drugs. And depending upon the ejection fraction, like the treatment options have been tailored. That is, if the ejection fraction of the individual is like more than 45%, these patients, they require the cardioselective beta blockers. And these cardioselective beta blockers, what do they include? Bisoprolol, metoprolol, your carvedilol. Carvedilol is both alpha plus beta blocker. Okay, so cardioselective beta blockers have to be given, and you have to start the beta blockers with low dose, and gradually you need to step up the dose depending upon the tolerability of the individual. And the other drugs are, the aspirin should be given. This will be the treatment similar to that of the coronary artery disease. Next is the AC inhibitors that will prevent the cardiac remodeling. And next is statins, because they have the pleiotropic effect. So these are the drugs that you need to give when the ejection fraction is more than 45%. And if the ejection fraction is in between 35 to 45%, then you have to give selective beta blockers, right? And with or without supplementation of the AC inhibitors, because those individuals with ejection fraction between 35 to 45%, there is high chance that the individual's blood pressure will be on the lower side. So AC inhibitors, you have to check whether the blood pressure of the individual is adequate or not. If the blood pressure is more than 90, then you can give the AC inhibitors, or angiotensin receptor blockers have to be given. And if there is airway obstruction, right, please remember the beta blockers, they are contraindicated. Right, beta blockers, they are contraindicated. Now, if the individual have developed complications like in the form of the cardiogenic shock, pulmonary edema and arrhythmia, accordingly you need to tailor the treatment. So complications have to be treated. So how do you treat these complications? Subsequently in the next slides I will discuss. Next is, so whatever we have discussed was mainly the treatment of primary Takotsubo cardiomyopathy, and you take the treatment for secondary Takotsubo cardiomyopathy. So these patients are those who are admitted in the intensive care units, and in these individuals, because of their critical illness, the coronary angiogram, it cannot be performed. Right, coronary angiogram cannot be performed because of their critical illness. Okay, so you have to diagnose what is the underlying medical, surgical or obstetric condition, and accordingly you need to treat the underlying cause. And once you treat the underlying cause, the individual's Takotsubo cardiomyopathy also will slightly try to recover back. But only point, see, this is a disorder where there is massive release of catecholamines. So that is the reason why dopamine or your epinephrine and norepinephrine, if you supplement, the clinical scenario will further worsen. So your dopamine, catecholamine, epinephrine and norepinephrine, usually they are avoided. Right, usually they are avoided. Okay, so now we were discussing about the complications. If ejection fraction is less than 35%, the individual can develop cardiogenic shock, arrhythmias, pulmonary edema. So how will you treat them? Let me just show you the table. So if the individual develops, the coronary flow is being reduced, right? So what did I tell you? In almost 2 to 10% of individuals, there can be mild atherosclerosis, because of which the coronary flow can be reduced, for which you need to give the antiplatelets. And if there is the apical thrombosis, where there is high risk of development of thromboembolic events, in them you need to give low molecular weight heparin. And you need to give cardioselective beta blockers if the ejection fraction, if it is reduced. Okay, and this beta blockers, like cardioselective beta blockers like carvedilol, metoprolol and as well as bisoprolol, it will be also helpful in reducing left ventricular outflow tract obstruction. Next one is the ACE inhibitors. ACE inhibitors have to be given mainly to prevent the LV remodeling. So whenever there is significant hypotension, what happens in these individuals is there can be activation of sympathetic nervous system, and that activated sympathetic nervous system or activated RAS, even RAS is also activated because of decreased renal perfusion. So this RAS, whenever it is activated, there will be increased afterload on the left ventricle, causing cardiac remodeling. So ACE inhibitors, they will prevent the cardiac remodeling. And if there is coronary vasospasm which is developed, you need to give calcium channel blockers, that is verapamil or diltiazem can be given. And if arrhythmias are developed, then you need to give anti-arrhythmic drugs like amiodarone or the disopyramide or flecainide can be given. If there is pulmonary edema, monitored dose of the diuretics should be given, because the problem of the hypotension. And not only that, whenever you are giving this amiodarone, you have to look for the QT interval, because amiodarone itself can cause QT prolongation. So you need to monitor the QT interval whenever you are giving this anti-arrhythmic drugs. And cardiogenic shock, you can give levosimendan, but if there is severe hypotension, mechanical support in the form of intra-aortic balloon pump has to be placed. Right, so what this intra-aortic balloon pump does, this intra-aortic balloon pump, it will increase the diastolic pressures within the aorta, and thereby it increases the coronary perfusion during the diastole. Okay, so that is about the mechanical support. But the problem is it is not always available in all the centers, right? And next thing is the treatment on follow-up. Beta blockers, ACE inhibitors and antiplatelets, they are the one which have potential benefit in long term. So these drugs have to be followed up in further OPD visits. Okay, but as such, there is no particular evidence showing that these drugs will be helpful, but these drugs have been found to improve the clinical outcome in the individual. So to differentiate whether it is an acute MI or Takotsubo cardiomyopathy, you just see this flow chart. So first and foremost, the patient has developed with chest pain. You have done troponin elevated, ST segment elevated, 2D echo showing the hypokinesia. Next important thing, that what you need to do, coronary angiography. If there is obstruction, you need to do revascularization in the form of the coronary artery disease protocol. And if there is no obstruction, think of Takotsubo cardiomyopathy, and then you need to do the risk stratification. That is, if the ejection fraction is 35 to 45%, where the individual did not develop complications, then you need to give beta blockers. Calcium channel blockers should be given if there is coronary vasospasm. Then ACE inhibitors should be given to prevent the cardiac remodeling. Aspirin should be given if there is mild obstruction, and statins should be given because they have the pleiotropic effect. But if the ejection fraction is less than 35%, where the individual is critically ill, then you need to give the treatment accordingly depending upon the complications. Like acute left ventricular failure, you need to give monitored dose of the diuretics, levosimendan, particularly if the patient is in a state of cardiogenic shock, and mechanical ventilation to prevent the respiratory failure. And arrhythmias, you need to give amiodarone or the beta blockers. And next, AICD, that is implantable cardioverter defibrillator, that too in a selected patients. If LVOT obstruction is there, then you need to give beta blockers, and apical thrombus is there, you need to give low molecular weight heparin. So this is how you need to follow up the treatment in patients with Takotsubo cardiomyopathy. In almost within 6 months, there will be recovery. That hypokinesia, akinesia, whatever is there, that will recover back within 3 to 6 months. Now, there are certain factors to tell that there is high chance of recurrence of this Takotsubo cardiomyopathy. So what are those factors? First and foremost, very, very important is the presence of severe LV dysfunction, where the ejection fraction of the individual is less than 35%. That tells there is high chance of recurrence. That is one point. Then there is increased susceptibility to emotional, right? Increased susceptibility to emotional or the physical stress. They are also having high chance of the recurrence. Next is the dynamic variation in the sensitivity of the cardiac adrenergic receptors, and females of age group around 50 years, they are also at increased risk of recurrence. And what are the drugs which can prevent the recurrence? So the studies have shown that it is the ACE inhibitors which can prevent the recurrence then compared to that of your cardioselective beta blockers, right? Multiple studies have been done, and these multiple studies have shown the ACE inhibitors, they are more preferred than compared to that of the beta blockers to prevent the recurrence, right? Now, the three important differential diagnoses that you need to differentiate is Takotsubo cardiomyopathy from acute coronary syndrome from the myocarditis. So you take the age of individuals. The Takotsubo cardiomyopathy, most commonly it is seen in postmenopausal females, whereas acute coronary syndrome, it can be seen in any age, and myocarditis, it is most commonly secondary to viral infection, and this is very common in the younger age. Whereas you take Takotsubo cardiomyopathy, it is more common in females rather than males, whereas males and females almost equally predisposed in myocarditis and as well as acute coronary syndrome. What about the trigger? The emotional or physical trigger should be there for the development of Takotsubo cardiomyopathy, whereas acute coronary syndrome, it is doubtful, plus or minus, okay? And even in myocarditis, you know, the trigger will be in the form of the viral infection, okay, most commonly. Even your bacterial infection can also cause myocarditis, but most commonly it is the viral infection. Next is the presence of the pericardial rub. So if you take this pericardial rub, it is seen in case of the myocarditis. Acute coronary syndrome, it may or may not be present, but when it is present when the patients with acute myocardial infarction develops a long-term complication, and that long-term complication will be in the form of the Dressler syndrome, where it is post-myocardial infarction pericarditis, there can be presence of the pericardial rub. And what about in case of Takotsubo cardiomyopathy? It is absent. And what about cardiac biomarkers? In case of Takotsubo cardiomyopathy, it is your BNP, pro-BNP, which is much more elevated than compared to that of your troponin. Whereas in acute coronary syndrome, troponin is much more elevated than compared to that of your NT-pro-BNP. Then what about in case of the myocarditis? Myocarditis, it may or may not be elevated. And echo, it will show the regional wall motion abnormality, and that is present in more than or equal to the distribution of single epicardial coronary artery. And even in acute coronary syndrome, the regional wall motion abnormality will definitely be present. Whereas in myocarditis, the regional wall motion abnormality, it may or may not be present. Coronary angiogram, there is no obstruction in case of Takotsubo cardiomyopathy. Whereas in acute coronary syndrome, definitely there should be presence of an obstruction causing coronary artery disease. Whereas in myocarditis, the obstruction will not be there in the coronary angiogram. What about the cardiac MRI? The cardiac MRI, late gadolinium enhancement, it is absent in case of Takotsubo cardiomyopathy, whereas late gadolinium enhancement is present in case of the acute coronary syndrome, and even in case of myocarditis, the late gadolinium enhancement will be there. And biopsy in case of Takotsubo cardiomyopathy will show that there is contraction band necrosis. Okay, the CBN stands for contraction band necrosis, and there is also infiltration of the inflammatory cells during the acute phase. Then what about in acute coronary syndrome? Acute coronary syndrome also will show you the necrosis, but it will be the coagulative necrosis. And what about in myocarditis? Myocarditis will show you that there is presence of the inflammatory cells. And what about viral etiology? Viral etiology, it is present in myocarditis, but not in case of Takotsubo cardiomyopathy or acute coronary syndrome. So these are the three important things that you should be able to differentiate from the Takotsubo cardiomyopathy, right? Now, if you see the conclusions in case of Takotsubo cardiomyopathy, first and foremost, this Takotsubo cardiomyopathy, we have two forms, primary and as well as secondary. So primary, you have an underlying emotional trigger, either positive or negative. Whereas secondary, there should be an underlying medical, obstetric or surgical event. And primary Takotsubo cardiomyopathy, diagnosed in 1 to 2% of patients admitted for acute coronary syndrome. The diagnosis should be based on modified Mayo's clinical criteria or European Heart Failure Association criteria. And this primary Takotsubo cardiomyopathy, it is most commonly seen in the postmenopausal females, and coexisting neurological or psychiatric illness are encountered frequently in Takotsubo cardiomyopathy. Next is the biomarkers. NT-proBNP is much more elevated than compared to that of the troponin in case of Takotsubo cardiomyopathy. And the echocardiography, coronary angiogram, cardiac MRI, they are the useful tools in diagnosing Takotsubo cardiomyopathy, and prognosis in Takotsubo cardiomyopathy, it is good in almost 90% of patients. Next is the risk stratification and proper management of life-endangering complications are essential steps in the management of the patients with the Takotsubo cardiomyopathy. And treatment may include beta blockers, low molecular weight heparin, levosimendan for cardiogenic shock, IABP for severe forms of cardiogenic shock, mechanical ventilation for the respiratory failure, LVAD and as well as ECMO, they are the mechanical pumps to improve the blood pressure of the individual. In-hospital mortality is hardly around 1 to 5%, and the chance of recurrence is around 5 to 10% of individuals, and it is very commonly seen in individuals with reduced ejection fraction, severe LV dysfunction. In them, there is high chance of recurrence, and even in females around the age group of 50 years, also the chance of recurrence is very high. So this is in toto about the very important clinical condition, that is Takotsubo cardiomyopathy. So most common clinical presentation will be in the form of chest pain, dyspnea, palpitations, syncopal attack, and there should be a preceding trigger, physical or emotional trigger. So this completes the discussion of your Takotsubo cardiomyopathy. Thank you very much.